Hey guys and gals, Salim Rizai here, and I put out a poll based on a hypothetical case of a patient with status asthmaticus. And this was the question. You have a 30-year-old female, presents with altered mental status, respiratory distress, severe asthma, and this is the initial ABG. And as you can see, she's got a very acidotic ABG with a pH of 6.92, an elevated PCO2 of 128, a PaO2 of 339, a bicarb of 22, and this is on an FiO2 of 100%. So she presented to the emergency department, got placed on a non-rebreather, and they just got a gas to see exactly where we're at with this patient. And I tell you, in addition to meds for status asthmaticus, which of the following would you consider next? And it was intubation, BPAP, or VV ECMO. And on YouTube, we got about 91 votes, and it was close between intubation and BPAP. And based on a lot of the comments I was getting, this was also the case. Intubation was 49%, BPAP was 46%. On X, we got 2,500 votes, and again, very close between BPAP and intubation, but in this poll, BPAP was the more chosen option, 48.8%. Now, I told you that this patient was altered, and a lot of the comments I saw were, well, how altered is this patient? And I would say that she's protecting her airway. I would give her a GCS of 12 or 13 at best, and she's not actively vomiting. This was the initial gas that I told you. Other things that are of note are she's never required intubation for her asthma. I'm telling you that she's altered, but I'm telling you she's like a GCS of 12 or 13. She's not like obtunded, but she's clearly altered when you see her. So my gut instinct when I walked in the room was I need to intubate this patient because she looks so bad and this gas is terrible. But I was concerned about a couple of things. First, she has severe respiratory acidosis, and my concern is by doing RSI, she's at a high risk for cardiac arrest. The other thing is that I haven't told you so far is that she was pulling tidal volumes of about 100 once we put her on BiPAP. And so my concern is that it was going to be really hard to ventilate her once I got her on the vent. And so I felt like a lot of her altered mental status wasn't the fact that she was exhausted and tired. It was the fact that she probably had a hypercarbic encephalopathy. So we did go ahead and do that BiPAP. And I did go ahead and get plan A, B, and C ready for rapid sequence intubation, including all adjuncts, everything that I would need, video laryngoscopy, direct laryngoscopy, bougie. I got epinephrine, calcium chloride, sodium bicarbonate. I got everything ready. It was all sitting at the bedside, but I decided to go ahead and try her on BiPAP. And there's going to be some people that maybe question that because of how bad the gas looks and because of the fact that the patient's altered. And I decided to give her a chance with basically kitchen sink of medications. She got a continuous albuterol neb at 10 milligrams. She got ipratropium with that, 500 micrograms. She got IM epinephrine at 0.3 milligrams. She got solumedrol 125 milligrams IV, 2 grams of mag sulfate run over 20 minutes. I did give her a bolus of lactated ringers, 30 mLs per kilogram for insensible losses. She was not hypotensive. I purposely have not put the rest of her vital signs, but she was hemodynamically stable, but obviously tachycardic. She also got IM terbutaline 0.25 milligrams. I did give her ketamine 1 milligram per kilogram IV so that she could tolerate the BiPAP mask. And then I set her on BPAP 16/5 with a respiratory rate of 20 and an FiO2 of 100%. This was her 1 hour gas. And what I'll tell you is that I didn't put her on BPAP and walk out of the room and go away. I actually pulled up a chair and I sat in the room with her. And I told you I already had all my plan A, B, and C and adjunctive meds and different things that I would need. And I can tell you that her initial tidal volumes were in the hundreds. And within an hour, she was up to 200s. And you can see the repeat gas is improving, but still not great. pH of 7.039, a PCO2 of 106. The PaO2, we dropped the FiO2 from 100 to 50. I saw some people making comments about hyperoxia in this patient, and so we dropped that down, and her PaO2 is now 161 on this repeat gas. I decided to keep doing what we were doing because I felt like her mentation was improving. Her heart rate was obviously elevated, probably from just the albuterol nebs in the clinical situation, but she still remained hemodynamically stable. She wasn't vomiting. And so I just wanted to give her another chance. And so I told you I had pulled up a chair. I was still sitting in this room. We did another continuous albuterol neb at 10 milligrams for a second hour, along with ipratropium at 500 micrograms. She got another 2 grams of mag sulfate over 20 minutes. I gave her a second round of IM terbutaline, 0.25 milligrams, started her on a ketamine drip at 0.4 milligrams per kilogram hour, and a Precedex drip at 1 microgram per kilogram hour, more for so she wouldn't mess with the mask and try and pull it off. I wanted to really make sure I was optimizing her. And the BPAP, we continued 16/5, respiratory rate of 20, and an FiO2 of 50%. At this point, when I got the second gas, I did have a discussion with the family about the need for intubation versus VV ECMO or a combination of the two. And after talking with the patient's family, they basically decided that they did not want to intubate her. They also had concerns about high risk for cardiac arrest and the difficulty with ventilation, and they chose for VV ECMO. And so I actually called the ECMO center that started to mobilize and started heading our way as we were doing that second round of medications that I just went through. Here's her 2-hour gas. 7.094 for the pH. PCO2 is now down to 80.6. Her PaO2 was 324 despite being on 50%, and her tidal volumes went from 200s to 500s. And so we actually turned the FiO2 down even more to 35%. And at the time of the ECMO team arrival is when the patient started kind of mentating better, started oxygenating better, and she was really clinically starting to improve. Her tidal volumes ultimately, while the ECMO team was doing their evaluation, went up into the 700s. She completely cleared her mentation despite being on the subdissociative ketamine and the Precedex. And at that time, she was refusing both intubation and ECMO. Here's her 3-hour gas, 7.256. PCO2 is now down to 57. Her PaO2 is 139, and she was on that FiO2 of 35%. And so she ended up not requiring ECMO or intubation despite the very tenuous situation. She got transferred to the ECMO-capable facility in case she began to deteriorate. At the time that she arrived to the ECMO facility, she was off BiPAP. She never actually required intubation, and she never required ECMO. So there were a few learning points that I just wanted to kind of go through with this case, because this was a really tough one. And I think most people would have been right if they chose intubation, and most people would have been right if they chose BiPAP. And this is the dilemma we all have to deal with. And I think there's no right answer. It's just every patient's going to be a little bit different. And for whatever reason, despite my gut telling me to intubate the patient, I decided to give her a trial of medications and BiPAP. And thankfully, it ended up working out for her. So the first thing I'm going to tell you is that know your meds and doses for severe asthma. Plan for the worst, but hope for the best. So I already got all my airway stuff ready. I had all my RSI stuff ready, but I really wanted to trial her and give her a chance. If you can manage the sickest asthmatic patient, which I would consider this a very sick asthmatic patient, you can manage all asthmatic patients. And so I frequently will do this, is that I will kind of present questions to myself in my non-severe asthmatics and say, like, if this happened, then what would I do? If this happened, then what would I do? And so I felt very comfortable running that laundry list of kitchen sink medications that I gave that patient. So I think that's the first thing, is just know how to treat the most severe form of whatever it is that you're treating. And so here's the list of medications that that patient actually ended up getting and that we should probably know for patients with status asthmaticus. And that is your dose of your continuous albuterol neb, the dose of your ipratropium, intramuscular epinephrine. Some people would say you can give 0.5 milligrams. I chose to give 0.3. I don't have any strong evidence to support that. That is just what I decided to go with. Don't forget about your steroids, and remember that steroids won't probably have effect immediately. They will require several hours before they kick in. Plus minus on magnesium sulfate, but I feel like, listen, it's a smooth muscle relaxer, and a patient that's this tenuous, I'll take any help that I can get. And so you want to give 2 grams IV over 20 minutes, and then you can repeat that up to 3 times. Don't forget about insensible losses. These patients, and this patient had been having an exacerbation for 3 days and had very decreased PO intake. And although hemodynamically stable, probably have a lot of insensible losses and are intravascularly depleted. So make sure you resuscitate them with volume. IM terbutaline is old school med. It has been years since I've had to use it, but it is something that we threw at the patient, and you can repeat this up to 3 times Q15 minutes. Ketamine doesn't kill respiratory drive, also has some bronchodilation properties. We gave her a bolus just so that she wouldn't pick off the mask and she would be able to tolerate that, and then ultimately started her on a drip. You can run this for several hours. The dose that I was giving her is kind of bordering on that no man's land, but it was meant for more of a subdissociative type of dose. You can also use Precedex to help with anxiolysis. It does nothing to treat the asthma exacerbation itself. It is just purely for the ability to get the medications to the patient. And then, of course, BiPAP versus intubation versus VV ECMO are kind of your airway modalities. And in this case, we decided to go with BiPAP. I did see some people comment on using CPAP. And as you could tell by her initial ABG, oxygenation was not the issue. It was more ventilation. And so I chose to go with BiPAP to try and help her with minute ventilation and tidal volumes. But you could go either way in this scenario. Learning point number 2, BiPAP can be used in patients with status asthmaticus, even if they have altered mental status like this patient. Now, I'm not talking about a patient who's obtunded with a GCS of less than 8, who's actively vomiting. I'm talking about a patient exactly like the one I'm presenting, which is their GCS is like 10, 11, 12, 13. They're clearly not normal, but they are altered. But remember, if you're going to do this, pull up a chair like I did. I sat in that room for almost a solid 2 hours. And you're going to need to monitor these patients as they can take several hours before their airway, as their airway bronchoconstriction starts to open up. But they can also get worse and require intubation. And so this is why you want to have everything ready ahead of time. And this is why you want to be at the bedside while you're doing this. This isn't a put them on BiPAP and walk away type of situation. Now, this is not a randomized clinical trial, but this was a great study, non-invasive ventilation use in status asthmaticus, 16 years of experience in a tertiary intensive care. Emergency Medicine, Australasia, published in 2018. I have the PMID number there for you. Now, this is the largest case series that I'm aware of patients with status asthmaticus. And in the case series, there were 176 patients that did get treated with non-invasive ventilation for their status asthmaticus. And the mean duration of non-invasive ventilation was 5 hours with a range of 2 to 11 hours. So you can see these patients take some time to really improve or declare themselves. The failure rate of non-invasive ventilation in this group was 8 out of 176 patients that got non-invasive ventilation, which was a failure rate of 4.5%, which is pretty low. And I think maybe argues that in some patients, we can probably start with BiPAP or CPAP and not intubate them, because the intubation, the procedure itself is scary because they can get more acidotic and suffer a cardiac arrest, but also their airways are so tight that we're just not going to be able to really ventilate them, and we're going to potentially blow out their lungs from the high peak and plateau pressures. And so to me, this just argues that there's no black and white answer here, but there is evidence that if you decided to go the BPAP route, which I did, and I found this study after the fact, after the case, that kind of supported what we decided to do in this scenario. Now, what was interesting, out of those 176 patients, they had 16 patients that had a GCS of less than 10 that they put on non-invasive ventilation. Now, I put non-invasive ventilation and patients that got invasive ventilation. So these were patients that ended up getting intubated and didn't get a chance on BiPAP. And they did an initial ABG and then they did a 2-hour ABG. And so let's look at non-invasive ventilation. So we can see the pH improved. It went from 7.03. They got put on non-invasive ventilation and that increased to 7.36. They also looked at the initial PCO2 and the 2-hour PCO2. And in Australia, they use kilopascals as their kind of thing that they measure. But we use millimeters of mercury in the US. So I've done the conversion here for you. And what you can see is their initial PCO2 was 117 millimeters of mercury. And that dropped all the way down to 64 with non-invasive ventilation. The invasive mechanical ventilation group had a pH that was a little bit lower, 6.94, but I would argue 6.94, 7.03 kind of falls in the same category for me. They also got better, 7.07 on their 2-hour gas. And you can see their initial PCO2 was very similar to the non-invasive ventilation at 115 millimeters of mercury. And then their 2-hour PCO2 dropped down to 82. And so both showed improvement, but it just argues that maybe some of these patients, we could start with non-invasive ventilation and buy them some time for those meds to kick in and not just go right to intubation. Learning point number 3, have everything ready for intubation, okay? Even if you decide that you're going to use non-invasive ventilation, work through your plan A, your plan B, your plan C. Have everything set aside and ready to go because these patients can crump like that. Have all your RSI meds ready. I'll talk a little bit about that. And any other medications you think you might need, just have it sitting at the bedside. And then any adjuncts like a bougie, a bronchoscope, a cric kit, whatever you think you might need, whatever you decide your plan A, B, and C are, have all of that stuff there so that you're not scrambling around and you can quickly move from A to B to C to whatever you need to do. Now, our patient ended up not needing intubation, but I had already pulled up meds. And because I already had her on a ketamine drip, my choice for the induction agent was ketamine. I pulled up 2 milligrams per kilogram, but with her altered mental status, I was feeling that she may not need the full 2 milligrams per kilogram, that she might only need the 1 or 1.5, but I went ahead and pulled up the max dose for myself. I chose rocuronium as there is evidence that because it's a non-defasciculating paralytic agent, maybe there's a better safe apnea time. And so again, anything that can buy me time to get that intubation should I need it. And I chose a dose of 1.5 milligrams per kilogram. So I went with a big dose because I could tell just even by the meds, although the blood pressure and the hemodynamics were fine, mentation wasn't good. There was a lot of insensible losses. And so I questioned how quickly the medication would get around. So I chose to go with a higher dose. If I was going to put her on the ventilator, I had already worked through this in my mind. I was going to allow some permissive hypercapnia, and this will help avoid auto PEEP in these patients. So they're going to have a really low respiratory rate on that ventilator, anywhere from 6 to 8 breaths per minute. I was going to do a low tidal volume, 6 mLs per kilogram of ideal body weight, not actual body weight. The peak flow on most of these ventilators is already set at 90 to 120. But in case you were using the ventilator to do BiPAP, a lot of people will turn that peak flow down to 60. So just make sure that you have your peak flow set at 90 to 120. And then your peak pressures are going to read high on the ventilator because this patient's bronchoconstricted. But what we really care about is the plateau pressure, and we want to ensure that our plateau pressure is less than 30 so we can avoid barotrauma in these patients. I also had sodium bicarbonate. I had 3 amps ready, sitting at the bedside because this patient was already acidotic. And although it was respiratory, I wanted to make sure that they didn't become more acidotic as I was doing the RSI. So I would have considered giving an amp or two before giving the RSI meds. I had epinephrine, both an amp of epi as well as push dose epi ready, again, to help me with cardiac output, and to help with getting things kind of around with inotropy. And then I had calcium chloride ready too. And my thought with this is that I really wanted to try and improve inotropy in this patient to circulate medications faster. So I had all of these kind of sitting to the bedside, on a table, but ready to go so that we weren't struggling. Luckily, I didn't end up needing to do any of this in this patient, but again, I was thinking through my plan and exactly my strategy of what I wanted to do. And then learning point number 4 is think about VV ECMO early in severe asthma exacerbations. Asthma exacerbations are a totally treatable disease. These patients are usually pretty young. They don't have a lot of comorbid conditions, but the meds need time. And thinking back on the case, I should have probably initiated consultation on the first ABG, but I ended up having so much going on that it was a kind of an afterthought. And it wasn't until the second ABG that I started to think about it as I was going through my plan. And that's when I actually contacted the ECMO facility. And thankfully they showed up, but the patient ended up not needing to be cannulated for VV ECMO. Tough case. I can understand if people have questions about things that were decided or done. I tried to do what was best for the patient at the bedside. I hope you guys enjoyed that. It gives you a lot to think about. I'm happy to take all comments, questions, and thoughts on the case. I appreciate you guys tuning in, and until next time.